Welcome everyone to the next installment in our seminars on responsible AI for health. Thank you all for joining us. Over the course of the last many seminars, we have built up to a point where we have talked about the challenges of AI, the advantages of AI, the promises. One thing that we consistently come about that we need to make AI better. At the same time, because sometimes the types of errors that may come in health by AI are unpredictable, and health is such an important topic that we need human oversight. So what we are doing today is we are discussing two very important things. First is agentic workflows. As you know that rather than using just one thing, by combining agents and giving those agents tools, we are able to create more grounding sometimes, more knowledge, more specialization. For example, if I want to read an X-ray, an agentic workflow would employ something to interact with, an agent that understands which narrow tool to use, then other narrow tools within the same workflow, so that a more understandable, more explainable, less potential for catastrophic error tool gets used. Yet from the point of view of a human who is using it, it could feel just like a chatbot on the front end with easy engageability, easy interactions, and things like this. Our expectations are that when we understand the right tool for the right job and the right chatbot type orchestrator that can engage with the person on the other side to deploy them correctly, we will end up with many less problems than we do currently. But many less is very far from perfect. And to be very honest, I'm not certain how good the evidence is that we will actually end up with very few errors. So the way we have thought about today is we'll start with Professor Mengling Morningfeng, who is one of the experts who has deployed these kinds of systems in Singapore and brings extremely important experience for the region in terms of how they are thinking about doing this. After his keynote, we will move over to a very distinguished panel. Many of you already know Dr. Kritika Rangarajan, Dr. Nirav Bhatt. Many of you have met Professor Swapnil Mishra. A full range of people, from people interested in epidemiology, data science, to hardcore computer science, to Kritika, who straddles the boundaries as a radiologist, also with a PhD from IIT Delhi, an unusual combination, and has been trying to deploy such workflows in radiology. So what we'll do after the keynote is we will shift to the panel and ask them some hard questions and see whether we can get consistent messages that we can all adopt, which might be good for the SEARO region after this. As usual, I'll always say, I think these days there are more questions than answers. And any real answers will take a lot of experimentation, research, deployment, and after deployment, more research to study the effects of the deployment. Because even today, if you look at the evidence on anything, you are still getting evidence on technical accuracy. You might get evidence on errors coming down. But as of now, we have so little evidence on things that matter, real outcomes, real things that change for patients, real satisfaction. And these things will always matter, and particularly in the SEARO region that itself heterogeneous in terms of resources, in terms of ability to deploy. I think these are all very valuable lessons. I'm not going to spend too much more time keeping you away from the main attractions, the keynote speeches and the panelists. So over to you, Professor Feng, for you to start us off with your keynote. Thank you so much.
Hello, everyone. Thank you a lot, Chair, for the introductions, and thanks a lot for the invitation. Okay, let me start sharing. All right. Yeah, my Chinese name is Mengling, or all my friends and colleagues call me Morning, so feel free to just call me Morning. Yeah, today, just briefly, to seed the discussions for the panel later on, just briefly share some of the projects that we've been doing under our AI for Public Health Center in our School of Public Health in NUS. My apology that I'm now actually in New Zealand. It's quite late in the evening now for me, so I may not be able to stay long for the panel. However, my co-director for the center, Professor Swapnil, will be joining the panel. So please save all the challenging and tough questions for him later on. All right. Okay, so some brief background about myself. I'm actually a computer scientist by training. I started doing the AI and machine learning research since 2003. And after my PhD, I went to MIT and Harvard to do my postdoc. That's where I have an opportunity to start researching on cross-disciplinary field on AI plus health and plus public health kind of research. And after my postdoc, I went back to the National University of Singapore and joined our School of Public Health. As mentioned, now I'm leading the new AI for Public Health Center. I'm also the domain leader for biostatistics modeling, AI, and data analytics. So I'm also the Associate Director of Research in our Institute of Data Science as well, allowing me to able to coach the computer scientist background or AI background PhD students as well. I was really lucky, some background history for the audience. While I returned to Singapore in 2017, if you still remember, that was during the recent hype of AI, and that the computer vision models are still leading the kind of pack at that time. At that time, the Singapore government already noticed the rising of AI and the need for investment in AI technology. So they invested 200 million Singapore dollars, about 150 million US dollars to set up this organization called AI Singapore to fund AI fundamental research application for AI technology in various horizons, of course, including healthcare, and the innovation of AI technology, meaning supporting startups in Singapore, and of course, capacity building in Singapore. With this abundant fundings, I am being blessed, allowed me to quickly set up my lab and start some initiative. That I have about a lab of 20 researchers now. Well, majority of them are PhD students, and the other half are postdocs. Okay, so for my lab, traditionally we have been working a lot developing AI technology for medicine, actually. For example, as mentioned, building computer vision models, analyzing various medical imaging mortalities, building models for treatment recommendation, etc. I believe the audience may share the same experience as well. In the recent years, very presently, we have seen some success in applying AI in medicine, ranging from medical imaging, electronic medical record analysis, automatic large language model based discharge summary writing, etc., etc. However, at the same time, we observed that the non-equivalent amount of effort or investment have been attracted to investigate AI for public health. However, we do believe that AI as a new technology have the potential to contribute to public health, where we may intervene more upstream. We can focus more on preventive health, disease surveillance, behavior nudgings, encouraging our population to have a healthier lifestyle, so reduce their risk for chronic disease, analyzing the social factors that may affect their health later on, use AI to generate more effective evidence to support policy makings, etc. So inspired by that, therefore we set up a new center together with Professor Swapnil, and these are the five sort of the pillars that our center focus on. Now, the middle pillar is our main job, that we will be customizing, developing, or most importantly, committed to deploy AI solutions to solve various unique public health problems. And of course, to enable the middle pillar all the way extreme to the left, is that first thing we need to do is to have good quality of data, large amount of data, and data across multiple institutes and probably even multiple countries. So therefore, one of the effort for us to do is to standardize data and integrate data for data development and data evaluation. For the effort, we've been working very closely with the Ministry of Health in the region, and also WHO for West Pacific Regional Office as well. And moving beyond that, of course, again, working closely with the Ministry of Health from our neighboring countries, and also WHO report office. We are also one of the thought leaders helping to shape the governance and then the ethics considerations, and of course, how to ensure responsible use of AI, especially when we are talking about using of AI to intervene and also interact with the entire population, right? That potentially create larger impacts, but also the underlying risk will be higher. And on the right-hand side, not just developing technology capacity buildings, both in Singapore and in the ASEAN regions or in the entire APEC regions, it is also something that we are very passionate about. And that's one of the reasons that why I'm in New Zealand, do want to learn from colleagues in New Zealand and aiming to develop some collaborations and joint capacity building programs across countries. And last but not least, we do hope that the use of AI in public health is there for good place, for good purpose, and is there to narrowing the already existing disparity in healthcare systems or resources accessibility to the population in the region, rather than widening these gaps in the access to health resources. Okay, and very busy chart. So in terms of technology, yeah, we work on anything from more traditional predictive AI, generative model to agentic AIs. But quickly to summarize the area that now we're focusing on includes infectious disease monitoring, AI used for support effective aging in Singapore and or ASEAN. AI for chronic disease management and mental health as well. So we won't be able to do all this by ourselves, and therefore we work very closely locally in Singapore with all the public hospitals, of course our Ministry of Health, Ministry of Education. In the region, as mentioned, we work with our counterparts, other universities in the neighboring countries, and the Ministry of Health as well, and of course the WHO report office. And again, I can't do this by myself, so I have very gladly have Spotnail by my side to support me along the way. Okay, so today I'm going to share like three agentic AI projects I've been working on, and like I say, hopefully that will see some discussion later on in the panel. So the first project I'm going to share is a project we collaborate with our ambulance dispatch call center. In Singapore, the number to call is 995 for ambulance. The unique, or maybe not unique, the challenge that our call center faces is that the call takers in Singapore, they're usually not medically trained, although they're educated and they went through some intensive training, but then they are not medically trained, and yet they're put on a very challenging task where required by Ministry of Health. They have to triage the severity of the patient just based on the phone call within 2 minutes time, and then of course based on their recommended triage, then the different levels of ambulance will be dispatched, or is also their task to identify non-emergency cases to then tell the patient or the caller that this is classified as a non-emergency case, so no ambulance will be dispatched, and that's very important because to save of course, to avoid wasteful usage of resources of our ambulance in the country, and also to avoid longer waiting time for patient in need. Okay, so here is a photo for me showcasing our system with our Minister of Health, Minister Ong. One very key feature in our solution is that in Singapore, we've been to Singapore, we actually speak Singlish, which is a mixture of English, Chinese, and Malay, and some other dialects. So our AI assistant must able to understand all this conversation in English, and then to help the call takers to extract all the key information and fill up the forms automatically for them so that they can focus on the phone call. And more importantly is that to detect the instant typed for them, and then based on the instant typed and according to our MOH guidelines, which have 100 over different types of protocols, to populate the list of questions that they are required to ask and get information, and of course later on recommend the triage level for the patient. So here I have short videos introducing the objective and some of the key technologies of our project.
When it comes to saving lives, a single call can be the difference between life and death. The 995 emergency line in Singapore is the first step to this, and ensuring that the right help reaches those in need faster and more effectively is crucial. This technology ensures that every call is not just answered quickly but accurately, sending the right help at the right time.
Triage is the medical process of sorting out patients according to their priorities. Today we face major challenges in pre-hospital emergency care. Our call volumes have been increasing at a rate of about 5 to 10% every year for the last decade.
At the SCDF Operations Centre, we use the Advanced Medical Protocol System, which has been highly effective in triaging emergency medical cases and deploying assets based on priority. However, we aim to push the boundaries further, especially when dealing with life-threatening cases where time is of the essence. The AI solution we are developing in partnership with NUS and NTU is designed to complement our existing systems by enhancing speed and precision of triage. Our goal is to enhance performance and further reduce response times, ensuring that every critical case receives the urgent attention it needs. With AI assistance, we hope to optimize the way we allocate resources, ensuring that our responses remain at the cutting edge of emergency medical services. By analyzing the caller's conversation in real time, the AI assistant will pick up keywords and analyze the tone of speech to provide insights to the call dispatcher through pop-up prompts for faster and more accurate decision-making.
The first function in the AI is an automatic speech recognition model. It's able to understand all the call conversation in the audio and transcribe it automatically into text. And the second component will be a natural language understanding unit that, based on the text, automatically extract all the key information from those conversations, including the address of the instance, the type of the instance, age and gender of the patient, the main complaints, symptom of the patients, etc. The key innovations in our AI model, first thing associated with the ASR model. Now compared to our previous prototypes, our current ASR now is capable to understand Chinese, English and Malay, all three languages mixed together. Working very closely with our team in NTU, we managed to improve the recognition accuracy for more than 10% compared to our initial versions. And together with both our natural language understanding module and also the ASR modules,
how we hope to see AI can help us is it can be faster, more accurate, and actually give objective support for our frontline call takers in their day-to-day operations.
I do see huge potential for AI to come in and create huge value as well.
Looking ahead, AI holds the potential to address many more challenges. As AI technology evolves, it will become even more integral in the management of public safety and emergency medical services.
When it comes
And following that, we have a recorded demo for our assistant. This is an actual call from our ambulance call center, but then of course we removed the patient IDs and everything.
Hello, 995 emergency.
And sorry, that is a bit
Hi,
soft.
good
The
evening.
one.
I'm calling from Vita Francis. I'm staff nurse Joanna. I would
So,
like
so
to
I guess
confirm
you can see
to
that the
the
first,
hospital.
of course, the
Can
function
you give
is
me your address,
the
ma'am?
AI is able to
It's
understand
91
the audio
Yishun
calls and transcribe
91 Yishun
everything.
Central.
And this is already very
Okay.
helpful for
So
logging
this is
purpose
Villa
and then
Francis
audit purpose for the
48H.
call
Yes,
center.
correct.
Which level?
5.
Level 5. And
And
your
as you
room
can see, as
of
the conversation goes on the left,
Room
the key
2, bed
information
5.
like the
bed
caller
5.
name, the
Okay, what
address,
happened to
everything
your
to be
resident?
automatically
My resident
recorded.
is
Male or
having
female?
stridor. Sorry?
Male or female?
Female.
Female. How old?
She's 87 years old.
87. Having what?
She's having stridor.
On the left
Stridor.
lower corner, if you can see that we
Okay.
have a sentiment
And
analysis.
then
Basically, there is to pick up
the
whether the caller
teleconsultation was
is
done this afternoon.
being stressed
So the
or
doctor
being very
said
anxious,
she's unrelieved.
to
Then
detect whether
we need to
necessary
transfer her
to
to the
remind the
hospital
call taker to
Oh, okay.
calm down,
So
calm
this
the
one, her
caller
main
down.
complaint is what actually?
As you can see now, it's detected to be a
stridor.
breathing problem and
Okay,
populated the
hold on,
5 questions that
You're
required
beside
by
her
the
right now?
Ministry of Health protocol that
You're
the
beside her right
caller
now?
She's
needs
in
to
the room. I'm
ask.
in the nurse station.
These are all in
Okay.
user interface. In our
She's
updated
conscious
user
and breathing,
interface, actually these 5 questions will
Sorry?
be
She's
highlighted,
conscious and
and
still
the
breathing.
non-answer
She's
ones
breathing
will be keep
She's having
flashing to
difficulty
remind
of
the
breathing.
caller to
Now
But
ask
she's
them
drowsy as
to
per
gather the
baseline.
needed information.
Okay, drowsy, yeah?
As per baseline la. That's her
Okay.
baseline.
Okay, can you hold on, Did she happen to choke on anything or not?
She's on NG2
Okay, can.
and she's on O2 right now.
Uncommunicative or what?
Uncommunicative.
Okay, hold on. Okay, I'm getting ambulance for you, but I need you to stay on the line to ask you a few more questions.
Okay.
Any coughing out of blood?
Sorry?
Any coughing out of blood?
No, don't have.
Don't have.
Yeah,
No
so as you can
coughing
see,
out of blood.
although the call has
Actually,
been going on, but then based on already
exclamation
existing
or any
information,
lung disease?
AI can already triage
So
to
far,
being
no.
P1
No,
plus, which
no
is the
choking
most
also.
urgent case.
No.
So
Okay,
by now,
ambulance
the
is already on the way to
dispatch
you.
team
Once
may
you're
already
cleared,
receive this
let
information if
she
the
get
human
back to you, and
corticus
please call us back
agree and
immediately for
acknowledge this
instruction,
and
okay?
Yes.
start
Thank
dispatching
you so
the
much.
ambulance.
Line 1 is
So yeah, behind the scene is a bit busy. These are the agents behind the scene. So in the middle, of course, we have a coordinating agent that gets everything work together. To begin with, we have an ASR agent that, like I mentioned, able to understand the Singlish audio calls and transcribe it to text, which is then feed to our natural language understanding, the context understanding agent. They will understand in context and extract all the key information needed based on our protocol and automatically fill up the forms. Then we have a dialogue management agent. This agent is the one that I'm trying to understand based on the understanding of the NLU agent, then to detect the instance type and then recommend the question to ask and detect whether the question has been asked. Like I say, if not, then keep highlighting it or reminding the corticus to ask those questions. And of course, last but not least is the agent to predict the triage level for the patients. And like I say, the middle agent is the one that coordinating all these. Talking about responsible use of agentic AI. So from a caller perspective, right, the caller actually do not even sense the assistant of the assistant of this AI assistant. There's still a human corticus answering them. At least for now, because although AI has been advancing quite fast, but there will still take some time for the public to fully trust AI being the one answering emergency call. At least that's our belief. We do have some colleagues from Europe develop similar agentic AI technologies for ambulance call, but their solution is that AI kind of replace the human corticus completely and take over completely. Based on our study, we find that probably the Singapore population is not ready for this yet. And get back to today's responsible or reliable use of AI topic. We do believe at the moment human-led agentic AI use probably a more suitable solution, right? Not only human in the loop, but in this case, the human caller are actually always in charge here. So what happened is that while the human caller taking the call, the AI will just work on this at the site with a screen, additional screen to the assistant system, and then providing the log of the conversation, all the automatic form fillings and the suggestion of questions, and of course triage. The human corticus are still the final person making the call, whether to agree to AI or take information from AI or ignore a recommendation for AI. Okay, so that's the first project that I was sharing, and expanding from the use of pre-hospital emergency care. We have also been discussing with our neighboring countries. One application they see is that, for example, for countries like Indonesia, Philippines, they are much bigger than Singapore, and some of their islands are actually quite remote and not so accessible for the villagers live on those islands. Sometimes the nearest health worker or doctor is another island that takes probably 1 hour boat ride. And in this case, the AI assistant may then come in without a human guidance in that case to fill in the gap, to provide at least the first cut triaging, then to hopefully recommend give the right recommendation for the patient, whether they need to travel to another island to seek help. But that's a very different use of case when really that in the very remote areas, there's not enough human healthcare workers. And in this case, then the AI may then come in, become an enabler to fill in the gaps there. Okay, then moving on, the second project I would like to share is a reinforcement learning AI agent for treatment recommendations. So reinforcement learning has been a very popular form of AI learning algorithms lately. Okay, I like to explain reinforcement learning by comparing them to educating our kids. Okay, I have 3 kids myself, and take myself as example. When I was a kid, was still a student, a young kid. Every time if I did badly for my exams, then my mom, being quite a tiger mom, she will bring out the canes, and then I know what's becoming. And then if I did well, of course, then she will, of course, buy me candies and hamburgers or McDonald's. Okay, every kids love fast food. Okay, all time, of course, me. Then I learned how should I behave at different time, and what's the desirable behavior that they will get me the reward and McDonald's and hamburger, not being hit by the cane. But similarly, for reinforcement learning, is that we basically put AI in simulated tasks and let them make decisions dynamically, and then we continuously provide feedbacks like positive rewards or digital penalties, right? So to inspire them to change their behavior to maximize their rewards along the way. So over time, they kind of learn how to behave under different situations. So in this case, we actually use a critical care scenarios to demo the power of this reinforcement learning agent. And the exact topic we pick is the recommendation of mechanical ventilation settings in the ICU, because the current setting protocols kind of is a one-size-fits-all kind of protocol, and many of these protocols were developed based on the Caucasian population. They may not be very readily adaptable to the Singapore or the Asian population. And of course, it definitely lacked the personalized level kind of recommendation granularity. So again, I have a short video introducing what we do here and in close collaboration with the ICU directors in the National University Health System Hospital.
The problem in ICU is pretty complex. We need to actually try to achieve an optimal oxygenation and ventilation for the patient, but not every patient is the same. We cannot have a one-size-fits-all solution. A personalized approach would help a lot, and that is where artificial intelligence might come in.
𝐸𝐫Zen is a reinforcement learning AI agent that developed in the Saw Hawk School of Public Health in NUS.
Reinforcement learning is able to draw in data from very diverse sources from our electronic health records and also dynamically from our monitoring systems.
The digitization of healthcare system and the use of electronic medical record has been going on for the last decade. So our 𝐸𝐫Zen AI algorithm has the benefit of learning from almost 10 years of electronic medical record. Our AI is basically there to condense, abstract, and summarize those knowledge,
and is able to integrate all of this information and learn from the data.
The AI actually learns dynamically. If AI makes the right decision aligns with expectation, we actually provide AI with some digital rewards. And if the AI decision differs what we expected, we provide a digital penalty to the AI. So over time, AI actually learns what's the best response and best recommendations for that particular state, and it is able to digest information in the near term and the longer term. It can also optimize the near-term outcomes and the long-term outcomes. The most important thing to bring our project to success is to have a very close collaboration with our physicians and our clinical collaborators to make sure that the design of the AI serves what they need. All the enhancement of the AI relies on their constant feedbacks as well.
AI is not going to replace clinicians, but it's going to help clinicians. At the same time, AI is not perfect, and therefore human clinicians should be there to verify and also to explain what AI has come up with. Ultimately, it's a collaborative approach, and merging these two together would be the best way forward for patients in future.
Okay, so yeah, to sum up the reinforcement learning project. So for that project, again, before we fully deploy it for clinical use, we want to make sure that beyond a experimental setup. It works well. So now we're actually running we call a silent trial in our National University Hospital. What it means is that the AI actually runs at the background for all the prospective cases and continuously giving its recommendation, and all its recommendation being logged. And later on, the intensiveness that we have been cooperating with, then they will review all these recommendations from AI and to ensure that it aligns with their expectation, and also AI is not giving something too crazy. And also slightly more on a technical perspective on the safeguarding this AI solution. Of course, reinforcement learning, as you may imagine, is basically allow AI to explore on its own and with the aim to optimize the reward, right? As I mentioned. So if we do not control AI, sometimes AI may explore some places really not acceptable, or kind of get some crazy recommendation. So to avoid that happening, so we actually control and refine the space that the AI can explore. What that means is that certain dosing, for example, we set dosing limits that it's impossible that AI give a dosage that will kill the patient. For example, tidal volume. So it's impossible AI will pump so much air that will burst the patient's lungs. And it was based on also learning from all the current guidelines. If some of the treatments are the combined use of these treatments will lead to adverse effects, that one we already automatically educate the AI that they shouldn't do that as well. So and of course, at least for now, the testing of AI and the first adoption of AI, still the human is the leading, the AI being the assistant. But surprisingly, while I was just discussing this project with Dr. Casey in the video, who's the head of critical care in our hospital, he compared to me being a computer scientist, he being a doctor is actually a lot more aggressive than I do. Witnessing the advancement of AI, he's actually hoping that in near future, AI can actually come in his words, a closed-loop automatically care system, rather than just providing recommendations every time waiting for the humans who act on it. His rationale is being that in ICU, probably a lot of decision makings are very dynamic and needs to be made quite fast. So sometimes I may not have sufficient time to consult the human all the time. And he also humbly somehow acknowledged that the human doctors sometimes may not know better. Okay, well, if the AI is supposed to learn properly, as I mentioned in the video, our AI is trained on the past decades of electronic medical records from the hospital smartly. The learning from the ones with good outcomes and distancing from the bad outcomes. So supposedly the AI will pick up the good knowledge and may know slightly better than some of the doctors do. So he's actually quite open for AI to do that. Just putting out for discussion later on. Okay, so yeah.
Please, Mohan, just a quick time check because we are slightly over time. So please, back to you.
So yeah, just one last one to share that we're also working an AI agent for active aging, which we built AI as a digital buddies to help our elderlies with some games as a front end to encourage them to exercise more and train be more active cognitively. Okay, so then since we're doing elderly, so we definitely will need more careful about not like feeding false information to elderlies and etc. So yeah, again, thanks a lot for attention. Here are some of the projects we're doing. Like I say, I hope that this will sit some of the discussion later on. And feel free to ask all the tough ones to swap you.
No, this was absolutely fascinating, including the first, just like you have Singlish. In North India, we call it English. And any solution that one builds must take into account a specialized language agent, a knowledge agent. But thank you so much. It's also very interesting to hear from you that if you use this kind of AI for ventilators, the tidal volumes need to be corrected so you don't burst people, but that's fantastic as well. But yes, I think you brought in wonderfully all the points of the power of these agents, but also the importance of human checks through and through. And we are very glad to know that the clinicians in Singapore are willing to take the frontier forward very fast. So thank you so much, Professor Feng.
No
You
problem.
can please stay on as long as you like, of course, but please also feel free because I know it's really late in the evening for you and you have important meetings tomorrow. But thanks again so much for joining us.
Okay, thank you much for having me. Okay, have a good day, guys.
Thank you.
Bye-bye. Enjoy the rest of the panel. Thank you. Bye-bye.
Okay, so with this, we move to the panel. And I think we already kind of know the most important thing that came. From the descriptions we heard from Dr. Feng, it was very obvious that if you create a ventilator agent that learns from everything, including the medical records, it does not in itself have a world model that tells it that this much of a tidal volume will be really bad for the patient. It just comes up with a number. Based on all the numbers it has seen, there is no real intelligence behind it yet. So, Dr. Bhatt, the question is really to you. When you develop these workflows, how do you balance the amount of autonomy that you would want to give to your agent versus the degree of oversight you want to leave for the clinicians? Your workflow could go much faster, much smoother if your agents are given a lot of rein to run. At the same time, the risks will go up. So how do you approach it?
Yes, so this is the fundamental question with each AI system, whether it's agentic or not agentic. So one of the way we try to first at training stage itself look at is bring any agent or AI tools to the human evaluator. So for example, we look at the drug discovery kind of where we build come up with the newer molecules. We ask medical chemists, does it make sense for you? Or even for clinicians, if there is outcomes or reports are there, they are showing certain patches or something. Is it really makes sense for you? Is it something new to you? And main thing we want to understand when most of the time agent, although we see many nice titles, catchy titles saying that AI do everything, but when we do real error analysis, particularly just little bit perturbation of the system, and you realize that 70% time it is okay, 30% time is failing. And what we should do, I think, when it comes to human oversight, before you deploy, is figure it out which 30% times you need human oversight. What are the challenges? Because the model does not, as you very clearly said, that it does not have a world model. I'm sure that doctors also may not have a world model, but they have something else which is they have acquired over here is what we call sometimes guts or experience, and the extra out of distribution, what we technically call it, or extrapolation ability is quite far better than any model in the world currently, right? So the point we try to do is that what are the limitations is the first point we should look at it. Thorough do the sanity check. What are the places the AI is going to fail, and bring human always in the loop before you deploy the AI. Human is always going to help improving AI from 70 to 80, 85, sometimes 90%, depending on how good model systems are. And I have seen that it is in any application, it is always helps. Expert domain clinicians who are going to use it, please take their opinion before you deploy it.
Thank you very much. So I'm going to continue on the same theme to Swapnil. Swapnil, on those 30%, the problems of, for example, if I give Pritika a junior resident who makes errors 30% of the time, she will probably feel stressed and supervise 100% of the cases. But on the other hand, in AI, sometimes you can predict what are the auto distributions, what are the within distributions, where the errors will be more, where the errors will be less. How do you approach this human oversight? How do you make it more effective? How do you think it is most meaningful in practice beyond just nominal human in the loop structures?
So thanks, Anurag, and thanks, Dr. Nirav, for your insights and obviously mornings, which I can take into. So I think I'll first actually make a statement which I actually hate about human in the loop oversight is essentially what I see is when as soon as you talk about human in the loop, most of the people think it is a checkbox that everybody wants to tick. And somehow I believe we have made that systems not to actually make anything safer. It's actually just making sure we can make someone liable, right? So it's not, so nobody is actually thinking to make a system safe. Basically, you just want to make sure that you have a scapegoat if that needs to be, right? And that's where the problem lies, because basically we are putting people's career at stake if you took it that way. And more importantly, a lot of this sort of human in the loop is also done by this person who is actually the most busiest, right? So essentially, you're not giving them any time to say no to or to evaluate anything. You are basically just, like, as I said, you're going back to those things. Therefore, my view is actually that if you have to really think on those things, it's not actually having a system where you basically create more alarms and you create more checkboxes, right? In fact, if you really talk to anybody at a hospital, and especially in India, right, what you will realize is what's actually more concerning for people is the amount of false alarms that are raised in all those systems. And basically, we have got to a system where if a system beeps, a nurse basically doesn't care about it, right? Because they are like, this is one of those false alarms. So that's not what we need. What we really need is how do we put a system view to it? And that's where I think all of this goes down to, right? Essentially, we are looking at this multi-agent agentic systems. We should start seeing them not as one system, like not as individual pieces of technology. This is a whole system that we are trying to look into. And what really works is whether you can put systematic checks into there. So basically, I'm not actually looking to put downward checks, but actually checks at the higher level of systems, where whether we can put systems where we basically have things at upstream that can be, which basically says, what are the permissions we have given? Is there a way where I'm not asking people to stop or check everything, but whether I have a way where I feel something is going rogue, I can just stop it, right? So one of those examples was the things that Morning said, that one of the things was, you do whatever you want, but these are the limits. You cannot go beyond this dosage. You cannot go below this dosage. You are not allowed to go there. Other thing is, even if you are doing autonomously, I have a way to say stop, and it stops, and it allows me to audit things, and it allows me to look at things, and you do it on the system level. So I think possibly that is what we need. And finally, what we also need is, again, this goes back to say, I can keep saying about this, is also that we are not necessarily catching the right kind of things at times, right? So generally we just say, you have ticked it, all good. What ideally we should be catching is at how many times we needed an oversight and how much of that oversight led us to stop something to happen, or it led us to stop something that really was bad. Because that's where you will be able to evaluate whether your guardrails or the things that you have put on, they really make sense, right? So I think in a way, if you'll ask me, I would feel like take a more engineering or a systems view of the things, put your guardrails on top on the system level, give an option in the middleware to basically stop things and have a full stop. Don't make, just for the sake of accountability, have a stop check everywhere, because as soon as you have so many checks, basically nobody looks at them. You don't give that person, a doctor or that nurse who is already overstretched with their work, to actually make a decision. You are just forcing them to say yes or blindly say no, and that's what we should be stopping. Possibly that's all. Happy to talk more if needed on that, but hopefully
Thank you, Swapnil. Your example on ICU beds beeping everywhere and nobody even going to check them is so apt, because I remember during residency there was not a single bed that was not beeping, right? You just learn to think of the beeps as part of the atmosphere of the ICU, and you learn to live. So Kritika, this is really interesting, I'm sure, because very often with AI tools they will throw up a huge list of findings, and exactly as Swapnil said, creating cognitive overload. And yet, the doctors aren't necessarily always helped in their workflow. They have become accountable simply because the AI throws up so many positives, but it becomes hard for people to function. How do you suggest that in the today's age, with all these softwares throwing up all kinds of false positives plus real positives, along with some false negatives as well, doctors maintain their agency, maintain their accountability, but without the huge cognitive overload that comes from half-baked tools?
So thank you for that question, and thank you, really, Professor Swapnil, for really bringing that out. I think that you really hit the nail on the head when you said what you did about throwing up false alarms, as well as really looking at the system as a whole. So I think the first thing that we need to do is, when we are thinking of building out a solution to a problem, I think we first need to address whether it is a real problem in the clinical workflow. I mean, really think about, are you helping the clinician over there? Or are you just adding to their cognitive workload? So if you are sort of helping out in the sense that you're allowing them to function and reducing the time that they take by preparing the report, let's say. So supposing you had to just feed in the impression and it's going to build out everything else. There you are reducing the time, and really looking at it as an adoption problem. Also, you're much more likely to get adoption in a situation like that. Whereas if you are adding to the amount of distraction, you're really not really helping, and people are going to find loopholes and ways to game the system. And if you had some compliances to say that you need to use these many number of times, if you just look at how the NCD portal worked, where you have data entry operators sort of actually filling out things rather than it happening organically, these things will get gamed, so they just don't get really adopted. But if a system really worked, and I'll continue from your resident example. So if you really had, if you had to think of AI as a good resident, and let's not take those cases where AI is really not doing well. And if you are over time able to develop trust in the system, then possibly I think it is, you can't avoid a situation where there will be some mistakes that slip through. I come from a system where we get pre-prepared reports, whether it's in clinical medicine, you get the patient worked up, and in radiology, you already get a resident to really fill out your the preliminary report before you actually do it. And there, what you rely on is, this resident, you think this person must have done a fair job, and there are times when things tend to slip through, and possibly that will happen with AI. I think that's that really depends on how hard you try to avoid those mistakes. But it also, on the other hand, really avoids it really sort of makes your system fast enough. But what it does also is it helps you really focus on the crux of it. Why are you able to get deeper into the diagnosis? Because suddenly you freed up that time that you would have spent going over what is routine, what would have been handled by the resident. And then it allows you to go deeper into thinking of why this could have happened. And I think that's possibly something that we should hopefully start seeing more of. Maybe we can get deeper into the science of it, and therefore sort of really move the boundary a little further while the easier tasks get done by AI. I mean, that's what I would hope for, at least.
Thanks. We'll go in the second round in the reverse order. So Kritika, you continue. So to your mind, if you were to look at a genuinely enabling AI's ecosystem versus a system that is technically very good but doesn't help you in the slightest, what is the primary difference? I mean, I'll say one thing perhaps that will perhaps give a direction as well. I mean, I sometimes wonder whether a radiologist being shown an X-ray software that gives a huge number of findings contributes more to overloads than to use, because the risks of a radiologist missing something critical are small, but lots of false positive bothering them are high, while a general medical doctor could benefit a lot from a chest X-ray AI. So should AI be calibrated to the user? Would one question that I'm asking specifically. But beyond this, a more general answer in your experience, because you have tried multiple systems. What distinguishes the useful ones from the technically good but useless ones?
Absolutely. I think I'll answer your second question first, which is, and the reason I'm doing that is because I think much too often the way we evaluate AI is based on things like accuracy. And that's not what sort of you want to do in a clinical workflow, and that's not what determines adoption at all. Why there is this big gap between what we see in papers and in lab and what we see in the real world is because if you're just you will never reach that level of accuracy that you manage to reach on a very clean data set, because the clinical workflows look so different. And therefore, I think the larger questions facing us are things like, who needs a push AI and who needs a pull AI, for example. Like if there was a system where we created where we had either a primary care physician, or let's take it one step further and say that the technician who's acquiring the X-ray had to decide on the triage on whether an X-ray goes to a radiologist read or does not go to a radiologist read. That will have to be perhaps a push AI. There is a degree of compulsion you want to sort of impose on this person and say that you don't want to miss things. And there, you're probably more concerned about things like negative predictive value. The accuracy of it detecting a finding such as fibrosis possibly has absolutely no implication on what happens to the patient, whereas we focus much too often on the accuracy of even detecting findings which in that clinical scenario will be absolutely useless. Whereas for a radiologist, who if you were to give an elaborate list of 17 features and say that this is there, this is not there, this is there, this is there, this is not there, it takes them twice the amount of time to just verify whether all this was correct or not, and this person is not going to use it. Whereas if this was a pull AI and I say that, okay, I'm not sure about what's happening over here and it's just not fitting the clinical scenario, let me see what AI thinks of. Then if I'm able to pull AI in that situation specific to that purpose, I think we'll achieve a much higher compliance, and the workflow really sort of gets sorted end to end. So to both your point and what Professor Swapnil said before this, I think we really need to look at it as a system problem end to end. And that's when we'll get better adoption and actually achieve something on ground.
Thank you very much. So Swapnil, in the context of what Kritika said, and looking at your own grants on chest X-rays and many other areas, what do you see as the very high potential areas for autonomous/semi-autonomous AI?
Okay, so I actually have a very boring answer here, right? My boring answer is the places where I think we're going to be winning most are the things that Kritika actually was mentioning and Nirav also mentioned earlier, which was essentially about doing honest, smaller things. So I actually don't think our biggest wins comes around diagnosis and those things. It actually comes around sorting out the paperwork, sorting out the coding system, sorting out the ambient notes, and making them actually be done directly, right? So in a way, I have talked with a lot of clinicians, right? If you go to an EHR setup and you ask people, why did you put this ICD code for this disease, not the other one? The real answer is, I typed up the disease. Whichever came as the first is the one that's in there, because I need to go and do my diagnosis, which basically means there's nothing wrong in it. Don't get me wrong. It's not the clinician who is wrong here. Clinician has scarcity of time. They cannot at the same time be there and do that, right? We are in a place where we have less doctors. And this is true everywhere, even in a place like Singapore. So what you really need is somebody gets that corrected so that when that data set is going to be used for a research purpose, we can get that corrected. So that win is a real win which we can do. The other win is a lot of our EHR or of our diagnosis data has been lying around as unstructured data. Making them structured and making them coherent is where we can make real wins. And these are small-term wins, which much smaller risks involved actually, right? And then where I actually do feel that we can get to things is, how do we make things which are scarcely available? So like the example that you said, Anurag, which is like, you don't have a radiologist specialist in villages and in smaller cities, how you can get those things diagnosed at least at the primary point of care faster, which does not mean it is the last leg of diagnosis. It's technically the first diagnosis that says, hey, I think there is some problem. Can you now make a move, right? Because people forget this problem, that for a village person or for a person far off, making a travel to a small place, like making a travel to their district head office or making a travel far, is actually economically way more worse than actually living with disease at times, right? So all those things are where I possibly think we can make things, right? And I would also say one more thing, right? I actually don't fear that we will have problem of AI being rogue. Actually, I actually feel the problem will come from the other things. We possibly will have AIs that will do almost everything correctly, but they will have some silent places where they will go wrong, and that's what we'll not monitor, and that things will get accumulated over time. And because we will never see something big, we'll always feel that we are correct. So that's the thing that we should actually cross-check ourselves against. So I don't feel it's the AI being rogue that will be problem. It's actually will be the problem the other way around, where it's a very simple AI system that's going wrong at very places that we are ignoring, and that keeps compounding. So I think that would be my first set of responses.
I think you also answered one of the questions by Bipin Kumar Rathod on how do you calculate risk-benefit ratio. And I think your answer, if I were to rephrase it, select low-risk problems and automatically the benefits start looking nicer because so low-risk problems of things that doctors don't want to do anyway, and then automatically the benefits are high because the doctors like it in their workflow. Risks are low because it's things like coding and things and improving workflow. In fact, if you look at the RCT data for all the AI trials being done, you see it in this dimension. It is the non-assisting the doctor in doing complicated things. It is assisting the health system in doing the smaller things where the benefits seem to be most well proven and the risks are the lowest. And to be honest, whether we are talking critical care or anywhere else, there is plenty of such work going on. I'm going to
So
quickly...
Anurag, just one thing I wanted to say to Kritika's point, which was quite interesting to say, was also I wanted to say in here, it's also about what you are helping doctor with, right? So they are not trained to make entries. They are not trained to make basically EHR systems work, right? They are actually trained to be good doctors and be a diagnosis, and they are great at. In fact, I was talking to a lot of radiologists, and it's same point as Kritika's, which was like the time it takes them to look at AI's output is actually way more time than they would have just looked at the thing and made a diagnosis, right? So that's all what we should believe in. That which goes back to I think for the bottom line answer is think about systems, don't think about individual small problems that way.
So Nirav, the last question to you. What do you see as the best governance, accountability, checking framework on the AI side?
This is a difficult question to answer, but let me take it from the individual point of view rather than so the governance and the standards and all these aspects has to be the way people has described this. It should be taking account all the stakeholders in general. As Swapnil mentioned, that are we looking for the human oversight to find out that responsible person? There's a very nice saying by someone of the IAS officer I know. He's saying that we have power to make executive decisions, but we do not make that executive decision. It means no one will take decision. If you are looking for the person to oversight there for being a scapegoat or responsible for that. And I think that when we talk about governance or creating a standards, we have to talk with every stakeholder, look at the AI as a tool or helping a co-pilot or rather than making a decision for us. Decision at the still we are not at a stage for many places in a clinical setting for AI to make decisions. Like one of the example talk about Kritika but we can do other things which are easy where we can straightforwardly do automation using AI. One example, Swapnil mentioned about creating a report, finding out right codes for the diagnosis for the diseases, or creating a report with the flags which they feel are incorrect. And the governance should look at those aspects. I mean, in India, we are looking at differently. In Europe, when they are more stringent about using AI everywhere. I mean, many of the apps which are available in India are not even available in Europe. So and we have a both side. If we constrain it, it has a problem. It has if you allow it, it has its own problem. So what we have to do is we have to take a stakeholder, make a wish list from the governance point of view, safety standard point of view. What I call it technically error analysis. We want to find out the use cases where the AI is making mistakes, and those are the oversight we want to look at it. Rather than looking at it as a number, why people have said we want to quantify. I like to look at the number because it makes sense for me, but for the clinical setting point of view, numbers are not all the things. Then how we can co-pilot AI is another aspect which we look at. Talk with the clinician, what they want. Sometimes they just want the simple things to them. If we give them with the AI, they will be very happy to make last mile, what I call a decision. making a report or making annotations, and those aspects. I think AI, if we can make rules and regulations which are around it, other than making a decision side, then the governance and the standard may be useful to push AI to the clinician. Otherwise, as Swapnil said, if I'm asking someone to be a scapegoat, I think we will never be able to implement anywhere the AI. Like, forget about in clinician. Even in my desktop, I want to do it. If you think that if I do something, so that governance should look at the individual-centric point of view, while look at or even I say individual in a professional-centric point of view, and AI should be more as an aid or co-pilot rather than a complete agent at many places. Particularly in many clinical settings, because clinicians are not looking for someone should make decision for them. They are looking for someone should help to make a decision effectively. And some of the mundane tasks can they pass it to the AI, where even if there is a mistake, which they can actually figure it out while they're making the decision quickly. And mistake may not have that kind of implications. Yeah. Thanks.
Thanks very much, Neera. I completely agree that I think a co-pilot mode that makes nice suggestions when asked for. That will be Kritika's pull when asked for, as opposed to keeps chattering all the time from the co-pilot seat is, I guess, what doctors are looking for. There are appropriate questions by Dr. Shiraj that, what patients want may be different from what doctors want. But by and large, health system deployment of AI so far is still targeted at doctors because, to be very honest, when it comes to patient facing, almost every AI in the world will come with a disclaimer, which says, no matter how nice my answer sounds, please do not use it. I'm not a doctor. So for the timing, I don't necessarily know that anyone knows how to do a push versus pull for those people. And equity is clearly going to be an issue going forward. I completely agree. There is, of course, for people who want to do health economics, what is the benefit of AI? What is the cost per decision? But to be honest, these are solvable problems only if we knew the cost of care. In America, they very often calculate, the cost of antibiotic therapy versus not, the cost of AI versus not. But you have to really then be able to measure the entire economic flows across the system. Kritika, I would imagine that's going to be impossible, for example, in a publicly funded hospital, because the costs are hidden behind the scenes. In a private hospital, it might be possible, but then that level of research integration of the data might be harder. Great questions, because to be honest, at the end of the day, we don't just need to know benefit or not, we also need to know cost of benefit. And one very important thing I will add to this before I wind up, we're already 2 minutes over time. I think everywhere we talk about cost of AI is fundamentally flawed, because the real cost of these models is much more than it seems to be. Right now, the tremendous rise in valuations of these companies, the stock markets, the monies flowing in, hides from us the real price of a $20 subscription to Anthropic or a free access to GPT. There is an environmental cost, there is a money cost, there is a tremendous amount of cost happening behind the scenes of AI. And I suspect no matter what we do, at this point, every AI, except for the small models, the old AIs and things like this, all agentic models at the very least will not be cost effective at this point in time if the genuine costs were understood. That's my gut feeling. If any of you disagree with that, please let me know. But my feeling is all these costs are hidden behind the carpet right now.
No, true. I just want to add one point. In fact, I think there's one more hidden cost that we don't see, which is, not really a cost of AI, but what is the cost of investing in the other competing technology is something that what would we have rather invested this money in, and what benefit would that have sort of brought about is something that we simply don't think about.
Very important. Opportunity cost of doing something else with that money. Absolutely. But anyway,
I think I agree completely with that we never there should be a right tools for right application. Yes. And there are tools which can do some jobs. I have a simple case that some things can be solved by standard image processing techniques, which is practitioners, low cost, And still people would like to put high-end tools, and
Yes.
it miserably failed in the industries. I have seen that, and the people have gone back to the standard tools. So I think that exactly you said that you and Kritika said that opportunity cost, and are we looking for the right solution for the right problem is something which in this whole cloud of AI, or what I call it, noise of AI, is sometimes getting disappeared. The signal is always disappearing in that, and we should think about that before we deploy AI anywhere, whether it is a small application or the big applications. And of course, no one cares about the environmental cost of AI. We all think that we move from the gas to electrical car, so there are no emission. It is not happening anywhere, but yeah.
And I must say that in a university, we are counting one more cost, the cost of potentially making students dumber and less skilled at what they do. And I know that even in doctors, that is a question being asked, will we be producing less skilled doctors in the future and things like that. So there's another potential cost that we all. But thank you all so much. I'm going to just assume that Swapnil agreed with everything over here. And
Yeah, I agree. It's just that
and
we
thank
can
you all
talk.
for
We can keep
listening
talking.
patiently
So
to us.
Yeah.
And thanks to the audience. Without you, this seminar would not be worthwhile. And for the entire team behind the videos who make this possible. See you again next month. And look forward until then. And thanks again, panelists. Bye.